Good evening, everybody. Today is Sunday, October 10th, 2021. Today is a case list defense webinar. Just with a show of hands, if you can raise your hand if you can hear me, if the audio is working properly. Very good. Thank you so much. I'm going to lower everybody's hands. Before we start, does anybody have any question about anything, about the exam, anything in the webinars, anything about anything? I'm just looking down the line here. So no questions. So is anybody interested in being on the hot seat? All righty. Ashy, I'm heading over to your direction here. It says you're self-muted. Are you there, Ashy? It says you're self-muted. Can you hear me now? Hello?
I'm here. Are you saying Ashley?
It says Ashy here, so it's Ashley?
Oh, yeah, I see. They've typed my name.
Oh, they spelled your name wrong. So sorry about that.
No problem.
All right. All right. So do you have any questions before we start?
No.
You turned in your list?
I did. I think it might be
Okay.
under Germain.
Okay, let's take a look here. Are you a generalist,
Yes.
subspecialist?
Generalist.
Okay. Any specific case?
No,
that
whatever you think.
you're worried about?
No,
I'm just
whatever
looking for it.
comes to you.
I do not see it here. Have you been on the hot seat for this before?
Yes. Only once, though.
Okay. Was it last month?
Yes.
Here, I found it now. Yeah. I'm just waiting for this to pop up.
Okay.
You're not seeing my screen, correct?
No.
Okay, cool. Good. I'm just looking through it here. I'm just making it bigger. Got a big list. I'm picking OB.
Okay.
Is that cool? All right. All righty. Case number 21. Can you just do an overview of what are increased risks in a twin gestation?
I'm sorry, which case are you looking at?
71.
Oh, 71. Okay.
Can you see it?
So
see my screen?
overall,
Okay.
yes, I can see now.
Okay.
Increased risk in a twin gestation. There's increased risk to the fetus and the mom. If we're looking at the increased risk to the mom, it can be increased risk of diabetes, hypertensive diseases of pregnancy, and then sort of a combination fetus and or babies and mom would be preterm delivery, growth restriction. Depending on the type of twin gestation, there's different risks. For example, twin-to-twin transfusion, and with like a monochorionic, monodiamniotic
So
gestation.
when you mean different twin gestation, can you go over the different types of twins that can occur, and at what point like, can you discuss also the timing of the ovum cleavage in addition to what the different types of twins are?
Sure. So there's dichorionic, diamniotic twins, which are generally thought to be the safest twin pregnancy. That can be either from two separate ovulations that become fertilized, or from one ovum that cleaves very early on. Then there's monochorionic diamniotic and monochorionic monoamniotic. The mono is considered the most dangerous because it's more, there's higher risk for twin-to-twin transfusion, cord entanglement and things like that. The mono separates the latest, except if we're looking at conjoined twins, which would be even past that, like over 7 days separation after fertilization. And then the mono-di is sort of in between the dichorionic and mono in terms of risk and separation.
Can you give me more specific dates in regards to the cleaving of all the types of twins you discussed?
So di would be less than 2 days, mono-di 3 to 4, mono 4 to 5, and conjoined over 7.
Can you also discuss for me how you counsel your patients in regards to mode of delivery?
It's really a shared decision making between me and my patient. It depends on the presentation of baby A, and it depends on risk factors for the babies and what the patient would like. If baby A is vertex, then we discuss that a vaginal delivery is possible, regardless of the position of baby B. If the patient is a candidate for a vaginal delivery, an example of her not being a candidate would be if she's had more than 3 previous C-sections or a placenta previa or something like that. However, we do discuss that she could have a vaginal delivery with baby A and then potentially need a cesarean for baby B or a breech extraction for baby B, which could be more complicated.
So let's say she elected to have a vaginal delivery and you deliver twin A in a vertex position, all goes well. Can you tell me what things can occur with twin B and how you would resolve it? I'm not necessarily saying go through a breech delivery, but what different things, like if you were doing the delivery, what you would be looking for, what would you be doing in the delivery room, so on and so forth.
Sure. So in general, I always deliver twins in the operating room. So she had a vaginal delivery for twin A. We'd already been in the operating room, and I have an assistant who's helping me with ultrasound to find out what is the position of baby B. So I'm really monitoring for anything like abruption, bleeding, cord prolapse after baby A delivers. And then I want to see what's baby B's position. So I can do that with ultrasound and digitally. And then potentially it could be.
What do you mean by digitally?
I'm sorry?
What do you mean by digitally?
Like with a
the
vaginal.
position. Are you there?
I'm here. Can you hear me?
Okay. Yes. So
I'm
you said
digitally. With
digitally.
a
Mhm.
vaginal exam, what presenting parts do I feel? Is the amniotic sac intact? That kind of thing.
So let's say the amniotic sac's intact. Will you be able to really palpate digitally the presenting part?
Unlikely without rupturing. It kind of depends on the station.
So what options, let's say the baby is non-vertex. What are options that you can do in regards to delivery of twin B?
If baby is non-vertex, theoretically there's an option of an external version. However, that's not really shown to be as successful or as safe in a twin baby B delivery. So there could be a breech extraction. I could do an exam and rupture the bag and pull the feet down and then facilitate a breech delivery, or try to do an internal version to a vertex position and then allow for maternal pushing efforts.
So how would you do an internal version into a vertex position?
I would use ultrasound guidance and then with vaginal hand try to internally turn the baby into a head down position.
And at that point, would she be ruptured?
Most likely yes, unless she had a very strong amniotic sac, but typically yes. The risk of trying to do that, of course, would be having a cord prolapse. So it's sort of dependent upon the position of the baby and the cord.
So would that be a simple thing to do to, if she's ruptured, to make her a vertex presentation, or make the fetus a vertex presentation ruptured in order to deliver vaginally?
No, typically I would attempt to have a vaginal breech delivery for baby B in that situation.
Okay, and how would you do that? Not going through the breech, but how would you start that process?
For her to deliver baby B.
Yeah.
So I would grasp the bilateral feet and pull down to engage into the pelvis, and then allow for maternal pushing efforts until the baby starts to crown, and then go through
Okay.
breech maneuvers
Okay.
at delivery.
Now, what are there? Would you be able to? Would you give every patient that has a twin gestation that the first baby is presenting as a vertex the ability to deliver vaginally, or are there certain situations that the patient would not be a candidate? Talking about in regards to the twins, not that she's a placenta previa.
Right. In regards to the twins, if baby B was much smaller, like there was a large discordance between baby A and baby B, then I would be more concerned about it not being a successful vaginal delivery for both twins.
So,
Or if
so
there
which
was,
baby has to be bigger?
I'd prefer baby A to be bigger than baby B.
Okay. Why is that?
If baby A is bigger, then we assume that she can adequately deliver that size baby. If baby B is bigger, then there's concern that she doesn't have an adequate pelvis, or it's not really been stretched. So that's not a great term to allow for the delivery of baby B.
Is there anything else that you'd be concerned about, or you would assess before you would give the option of a vaginal twin delivery for a patient?
If the babies have medical issues that are known that would increase their risk of a vaginal delivery, like coagulopathies, or I'm worried about IUGR for either of the twins, then something that's stressful, I maybe wouldn't suggest a vaginal delivery.
Now, in regards to the prenatal care in a twin gestation, what testing would you be focusing on, or do more of in comparison to if she was a singleton?
In a multifetal gestation, I typically have maternal fetal medicine do the anatomy ultrasound and potentially fetal echoes, especially if they're IVF gestations. And then I start.
Why is that?
For IVF gestations, there is increased risk of cardiovascular disease or malformation, so it's recommended that they have a fetal echo after the anatomy ultrasound.
Okay, continue.
So I would have maternal fetal medicine involved, and then typically I start non-stress testing twice a week around 32 to 34 weeks, depending on the type of twin gestation and if there's any other comorbidities. And then also for twin pregnancies recently, ICUC has sort of changed its stance about checking a cervical length. So at the anatomy ultrasound, I'd at least check one cervical length. And then depending on if there's any shortening, we could talk about options after that. And then for di twins, I usually deliver at 38 weeks, unless other medical comorbidities suggest delivery sooner than that.
And what about mono-di?
34.
How about mono-mono?
36 to 37. I'm sorry, I have that switched. 34 mono di, I'd do 34 to 36.
So you start doing antenatal testing twice a week on di twins?
Yes.
What are you looking for in that situation?
I'm looking for reassuring tracings for both twins.
But you said the safest twins would be di, correct?
Correct.
So what are you looking for in that situation compared to, say, mono-di?
Well, in general, twins have a higher risk of having growth restriction. So I'm just looking for a normal reactive fetal tracing at that stage, and trying to assess if there's any other issues going on.
Would you manage a mono differently? Let's say a mono di.
A mono, and a mono di would also do antenatal testing, although there's a higher risk that they have, like mono have twin-to-twin transfusions, so they might require BPPs and potentially Dopplers. So that would be slightly different. And I would do testing sooner for them.
What do you mean by sooner?
Starting at an earlier gestational age, by like 32 weeks.
And you would deliver, you said, by 34?
For mono.
Anything else you would do in their management different than the other sets of twins?
Similar, they would be managed, co-managed with maternal fetal medicine, and similar imaging studies, but other than the earlier testing and earlier delivery, I wouldn't offer any other different management.
Any other testing you would do just in general for a twin gestation in comparison to a singleton?
I will typically do a growth ultrasound, whereas with a single gestation that has no other medical concerns, I don't necessarily need to do a growth ultrasound unless they would go into a late-term pregnancy. So I would do growth ultrasounds about every 6 weeks for twins as well.
So how do you calculate a twin discrepancy or discordancy?
It's the weight of the twins subtracted from each other divided by the total weight.
So repeat that again for me. I'm sorry. You subtract the weights of the twins divided by the total weight. So I'm going to make this up. Let's say twin A is 2,000 grams, twin B is 1,000 grams. So it would be 1,000 divided by 3,000. Am I correct?
I need to look that calculation up again.
Okay. How do you determine chronicity and amnionicity via ultrasound?
It's best to determine that at the very earliest ultrasound and to document what the dividing membrane looks like. So with the early ultrasound, you can look for either a T or a lambda sign, the T being more being diagnostic for monochorionic and the lambda dichorionic.
Anything else you'd be looking for?
You can also look at, in early ultrasound, it's more difficult to look at placentas, but you can look at, you know, do they appear conjoined? That would be very rare.
But they usually at some point appear conjoined with time.
I mean, the placentas, yes, but I meant the fetus.
If you had conjoined twins?
I have never known.
Is that what you're saying when you see the twins? Because you said something about conjoined.
Oh, I was saying that's something you could look for if you're looking for two separate sacs, but mostly for chorionicity, we're looking at the separation of the membrane.
Okay, let's stop there.
Okay.
What do you think? I wanted to focus more on twins, let alone, because they could have sent you down to do breech delivery and all that, but I wanted to focus more on twins because we'd done breech earlier in the week. You're ready to pounce on that.
Yeah, there's definitely some things I want to look into again.
All righty. Do we have an MFM on the line? I'm gonna see. I'm gonna be telling you the right stuff. Anybody is an MFM? I'm gonna lower everybody's hands, okay? Do we have an MFM on the line? Caitlin, I'm trying to unmute you. Are you there?
Uh-huh.
You're an MFM?
I'm a second-year fellow, yeah.
Okay. Anything that you would correct with what, and not putting anybody on the hot seat, because I think Ashley did a good job in regards to delivery. To my understanding, you either do an external cephalic version on twin B or you do an internal podalic version. It's where you literally go and pull the legs down and deliver as a breech. You can't really switch it as a vertex inside the uterus. Am I correct?
Correct.
Okay, because that's I've heard many candidates tell me that, and I'm like, I've never heard of it, but I want to make sure I haven't missed a new technique, so to speak.
Yeah,
So
not
that
that
is
I'm aware of
correct.
either. That's not something that we offer.
Okay, are you there on the call, Ashley?
Yes, I'm still here.
Okay, so that makes sense. So in order to deliver that second twin, you either do an external cephalic version or you do an internal pedalic version. In essence, that means you grab the legs, like you said, and pull down, and you deliver the baby as a breech. And hopefully
Mhm,
the membranes don't rupture. They usually
mhm.
do, and that's why it's time sensitive.
Right.
Again, I've never heard you trying to convert the baby as a vertex internally if it's, let's say, a transverse lie.
Okay.
Am I making sense?
Yes.
Now, Caitlin,
Hmm.
question for you. If somebody has mono, isn't the recommendation admission at some point and delivery by 32 weeks?
Yeah, so we'll usually start like TTTS screening and all that at 16 weeks, and then just essentially shared decision making at the point where the family would want intervention, decide when to admit. Some usually between 23, 28 weeks, depending on patient preference, and then delivery at 32.
Because you should not go beyond 32. Because I believe, Ashley, you said 32 to 34 for the mono, and they would need to be admitted.
Hmm.
Like they're a ticking time bomb. Let's put it that way.
Right.
How do you guys verbalize that, Caitlin, within your circles? I mean, you're a time bomb because those babies can die at any time.
Yeah, just that they're at a risk for essentially unpredictable and spontaneous stillbirth given the risk of cord entanglement. So that's, of course, the reason
Exactly.
for admission for immediate intervention abilities.
In regards to the timing of ovum cleavage, I thought the way you presented it, Ashley, was real nice because you didn't know 100%, did you?
Correct.
But I thought you did a nice job. That's real nice test taking technique where like I don't really know, but it's gonna be greater than 7 days. Da da da. This will be I mean, very nice, very nice. I just wanted to be like snippy and say, well, can you give me the exact dates? So
Mhm.
according to what I reviewed on up to date, day 2 to 3, die, which occurs 30% of the time. Day 4 to 5 for mono die at 68%. Day 9 to 12 mono that occur 2% of the time. And anything greater than day 13 is the conjoined twins. Okay.
Okay.
How do you calculate twin discrepancy / discordancy? Subtract the twin weights and divide by the larger twin,
Larger twin. Okay.
and then multiply it by 100 so you can move the percentage point. Okay. How do you
Yeah.
determine chronicity and amnionicity via ultrasound? Junction of the membrane with the placenta would be in the mono a flat T sign, in the die twin peak or the lambda sign. Thickness of the intervening membrane in the die is greater than or equal to 2 millimeters. Mono would be less than 2 millimeters. Layers of the membranes, die would be 4 layers, mono would be 2 layers, and it would be appearing thin and hair-like. Okay. Anything else you would correct, Caitlin? Because I thought she did a good job.
Yeah, I think those are the main things.
Anything else? I didn't want to go into the delivery of the breech. Don't forget to do an early glucola. That might be depending on the patient's BMI. I know in some practices, if you're twins, you automatically get a baseline 24-hour urine with your PIH. I call it PIH. And your preeclamptic labs as a baseline if anything changes. Anything else you would add, Caitlin?
No, I
I'm
don't
sure
think
I'm
so.
missing stuff.
Baby aspirin, I don't remember if you said that would be the only
Yeah,
other
she
thing.
has it
So
here
that's
on
on
her
the
list. She
list.
has it on her list, so that's why I didn't bring it up. Also, you personally brought up, Ashley, the cervical length. I could have gone in that direction. So hopefully, I'm assuming you knew about it because you brought it up. So
Mhm.
that's another avenue we could have gone into
Mhm.
because you brought it up. All
Okay.
righty. Any other questions on that, Ashley? I think you did a great job. A nice test taking, taking technique and saying, you didn't outwardly say I don't know, but you answered it in such a nice way, the cleaving, that I would give you the points for it. But we're doing the webinar, so I had to go back and say,
Right.
well, give me the exact days. But that was
Sure.
very nice, and that's just being smart. I think
Right.
all of us have that type A personality, and it's very easy to say I don't know. No, you smooth it over, and you're gonna get credit for it, or at least partial credit instead of zero.
Great. Thank you so much.
You did great. Caitlin, I'm gonna keep you on the line if that's okay. I'm gonna go to you next if that's okay. I have a question here, but great
Yeah,
job,
sounds good.
Ashley. Okay, hold on. I got Carissa. What is the discordance cutoff for proceeding with a vaginal delivery with breech extraction?
20%.
There you go. We got the MFM on the line. So 20%. I mean, I'm gonna be honest with you. It's very, I mean, I'm sure, Caitlin, in your fellowship, have you done that second twin as a breech? Or you guys section?
Yeah, we do.
You guys have been doing it?
Mm-hmm.
Also, I know gestational age is an issue. Can you elaborate a little bit more on that?
Yep, a lot of people won't do it before 32 weeks, and then also just a weight cutoff. So I think 1800 is the like true recommended, or 1500 is like actual recommended minimum, but some people won't do it until 1800 just because of the possible error with ultrasound.
And because I remember reading an up to date, again, I'm a generalist, that be very cautious between like at 28 to 30 weeks sometimes with that second twin, because the head is so much bigger, so you can get more of a head entrapment. Am I correct? Or am I saying
Right, I
those
think
dates
that's why
wrong?
32 weeks is where like a lot of people will feel more comfortable, just because that's kind of the time where you start to see the reversal, like the head not being so much larger than the belly. So definitely before that, I would be much more cognizant, I guess, of how I counseled the patient, but we don't routinely offer before that because of that reason.
Any, because I know there's a lot of micro preemies, and I know in some situations, if you have like a 24-weeker, some people would, I'm talking about twins, they would go ahead and do a section. But is there a cutoff on the lower end? If you're less than 25 weeks, as an example, you can try and do it vag with that second twin being a breech extraction, or not necessarily? Because when I was a resident, we had those cutoffs. It was like between 28 and like 32. It was like a big no-no. You had to section them. While less than 28 and above 32, you can try. Is that still the same, or that's changed?
Yeah, I don't think, I mean, if they're wanting full intervention for both babies, at least where I'm at, no one would offer below 28. I don't think that the only
Okay.
reason we would do a breech, like a planned breech delivery for a baby that early, would be if there was like not going to be intervention for it. And I don't know if that's just a local thing, or that would be
Okay, so
everywhere, but
anything less than 32 weeks, you would offer C-section,
yeah.
regardless of positioning of the babies.
Oh no, I mean, I'm sorry, I thought you meant only for a breech extraction.
Well, let's say they're both head down, right? But you could always have to, the kid could flip once
Right,
it
it can
delivers,
flip.
right?
So I think most people tend to counsel more in that direction. There may be some who are willing to offer it, but yes, because the risk that the second baby flips regardless, I don't know that we really do many. I can't think of any vaginal deliveries of twins below that gestational age since I've been here.
Okay, so anybody above 32, you'll say, hey, the second twin looks breech, we're gonna go for that breech extraction. Anything less than 32 weeks, you would recommend the C-section.
Right, as long as they're above that
Okay.
1800 and that less than that 20% discordance.
Oh, I would hope so.
Yeah.
Hopefully for 32 weeks, you're, who knows, maybe not. I have another question here saying, can you elaborate on the fetal echo on ART babies after the anatomy?
So that's like
Yeah,
a new
stuck here.
thing that may not be. So routinely, I think most practice still do fetal echoes after IVF, but there was a recent updated statement that it may not be the most cost effective and may not be necessary. I know where I'm at, and I think most people I've talked to elsewhere are still doing it, but that may be something that we see change in the future, that we are no longer routinely doing fetal echoes for those patients. But I don't believe, as far as I'm aware, that
for clarification, if you're a set of twins, they definitely would like you to have genetic testing, because you must counsel the patients of the increased risk of chromosomal anomalies. That's a must. Definitely, if there is a family history of cardiac, definitely you got to do your echo. And then, of course, when you have the reproductive assisted, I know echoes is recommended as well. That's to my understanding. Would you change any of that, Caitlin?
No, I think most people are still recommending echo for ART. It may be changing, but I would still like stick to that for this exam right
Right.
now because I don't think we fully move that way.
Okay, perfect. Any other questions, guys, on the line? Because we have an MFM here, so she can correct any of my errors. Okay, what is the standard for measuring cervical length in twins, and what do we do if it is short?
So again, I feel like that's a little bit controversial in general as far as when and people will and will not offer cerclages for twins. You can still do, the usual vaginal progesterone and stuff, but I think there are places that will do cerclages in twins. We do not do anything aside from exam indicated cerclages because there has been data to show that placing like a history indicated cerclage in twin pregnancy may actually increase the risk of preterm birth.
Now, what are we looking for measurement? Is the measurement less because it's a twin gestation? Let's say if she had a 1.5, you would say maybe a cerclage would be warranted, or less than 2. Does that change because of the twin gestation?
Not that I'm aware of. I think the measurement is still less than 25, but it's just like the criteria for, I don't know that everyone would do a cerclage in twins unless it was exam indicated. It's just a little bit more.
But in your center, if anybody has a cervical length less than 25 millimeters with twins, they would recommend at least the progesterone.
Well, we're in part of a trial, so they would get offered a pessary as part of like a research study.
Let's get the pessary out of the way.
But
I know
otherwise,
that's really
progesterone would be.
Now, let me ask you this: if she was a singleton, would you offer at 25 millimeters or at 20?
Less than 25.
So always 25, because I've worked in some centers where it's less than 20 millimeters.
I think that got updated in the most recent practice bulletin.
Okay, and then I'm behind that one. Okay, cool. Because 25 it's a good size length if you think about it in comparison to 20. Does that answer your question, Rebecca? So definitely you give the progesterone. It's questionable in your center if you would do the cerclage. Am I correct, Caitlin?
I think that would depend on who you're asking and everything.
Because different MFMs have different viewpoints and theories.
Yes.
All righty. Okay, well, hopefully that answers the question, because again, we have an MFM on the line, so that's awesome. Okay, so let me get to your list here a second. I'm a little bit slowing down here, so give me a second. Caitlin.
Okay.
Are you there, Caitlin?
I am.
Okay, I thought I lost you. If I lose connectivity, just stay with me, and I will get back on a hotspot and get back to you guys. So we're not going to do OB with you, Caitlin, because you're an expert. You submitted your list, correct?
I did.
Okay. So you're looking GYN or office?
Either one.
Okay. Bear with me, the computer is slow. You're still with me?
Yes.
Okay, just making sure. Because all of a sudden the computer's going a little bit slow here. Just looking for yours. Any particular case in your office that has you worried?
I don't think so. I think just in general, obviously my patients are all pregnant, so I know they're going to twist that some. So I think just.
Of course they will, because that's what they do. Oh, bless you.
Thank you.
Was that the dog? I don't know.
No, it's my husband.
It was a little bit, maybe you went away from. Yeah, I do see. Interesting. I'm trying to think what we can do here. You probably know more than I do about these type of things. All right, we're gonna do case 30.
Okay.
You should be seeing it here in a second. You see it?
Not yet.
Or not yet? People can see your screen. You see it?
I don't. I can pull it up on my computer. I see it. I've got it pulled up. I don't know if everyone else can see it, but I have it on my computer to know which one. The primary infertility uterine septum.
Yeah, hold on, because the computer's kind of going slow. So I don't know if it's me or the GoToWebinar guys. Can you see the screen there? You're still there
No,
with me,
I am.
Caitlin?
Yes, I'm here.
Okay, but at least I have your audio, so with a show of hands, can you see my screen, guys? And of course, I can't move. It's like going real slow. You're still there, Caitlin?
I am.
Are you there, Caitlin?
Yes.
Okay. So we're not losing. Interesting. I cannot lower the hands. Everything's going in circles.
Oh, I can see it now.
Okay, I think I have something here. Hold on. You can see it? Okay, sweetness. I don't know if there's a connectivity issue, something with GoToWebinar, but I'm still able to talk, so that's the weird thing. So I'm on the screen, correct?
Yeah, I can hear you and see it.
And you can hear me, perfect. Okay, so case 30. What is primary infertility?
So a patient who is unable to achieve pregnancy within 12 months if she's under the age of 35 or 6 months over the age of 35.
And what are some causes of infertility?
So a large portion are unexplained, but you can also have male factor and ovulation, medical comorbidities, so things like thyroid disease, abnormal cavities. Those would be kind of the first highest on my differential.
Anything else?
Not that I'm thinking of right now.
So can you give me a differential on recurrent miscarriages?
So you could have a balanced translocation in one of the parents, which would result in an unbalanced translocation in the offspring, resulting in miscarriage. Again, there are certain uterine cavity abnormalities that can result in miscarriage. Antiphospholipid antibody syndrome, medical comorbidities, again, such as thyroid disease, uncontrolled diabetes. Those would be kind of the
Anything
more
else?
common.
Anything else?
That would be where I would start.
So how would you test somebody for antiphospholipid syndrome?
Typically, you would order, so I would only do testing on someone who had a clinical criteria. So either, and on this topic, 3 losses less than 10 weeks or 1 greater than 10 weeks of a morphologically normal karyotype gestation. And then they need to have laboratory criteria. So beta-glycoprotein, anticardiolipin, or lupus anticoagulant, and they need to have positive testings of at least one of those 2 times at least 12 weeks apart.
And let's say the patient meets criteria.
Mm-hmm.
and you test her, and she's positive, how would you manage that patient in her pregnancy?
I would place her on a baby aspirin as well as prophylactic low molecular weight heparin.
Regardless if she has a history of VTE, you automatically would treat her?
Yes.
And for how long would you treat her, and how would you treat her?
So I would treat her throughout the pregnancy. Typically, we start aspirin at 12 weeks, but low molecular weight heparin throughout the pregnancy with plans to hold it around the time of delivery. You can either transition to heparin closer to term at 36 weeks, or what we do in my practice is continue low molecular weight heparin and then just have a planned delivery at 39 weeks so patients can be advised when to hold the medication. And then we just also counsel them in the office on indications for holding if they think they're in labor. And then after delivery, depending on the patient's personal history, so if they have had a history of clot, I would continue that for 6 weeks postpartum.
If she didn't have a history of a VTE, you would not continue it in the postpartum period?
I don't think you have to. You can. That's, I think, an option either way.
Now, can you tell me different congenital uterine anomalies
Yeah, so you can
that
have
can lead to recurrent miscarriages?
uterine septum is one of the more common ones that lead to recurrent miscarriages. You can also have a bicornuate uterus or a uterine didelphys.
Anything else?
Or an arcuate uterus.
So what's an arcuate uterus?
So an arcuate uterus, I don't know how to explain this. Looking at it, like you don't have, there's an indentation you'll see on the fundus, but it doesn't go more than 2 centimeters into the cavity.
Now, do you have an increased risk of miscarriages with an arcuate uterus?
I don't believe so.
So you should be able to get pregnant without any problems and be able to go to term with an arcuate uterus. Are you sure about that?
I'm not 100% sure. I'd have to double check that.
So if somebody has a congenital uterine anomaly, what are you also increased risk for?
So in addition to infertility and recurrent pregnancy loss, if you do become pregnant, you're at an increased risk of preterm delivery or malpresentation requiring cesarean delivery.
Anything else you could be at increased risk for?
There are also renal anomalies that are associated with Mullerian anomalies. So they may have like renal agenesis on one side.
Which side?
I'm not sure if there's a predominant side or not. I'd have to check that.
Any other organ systems going to be affected with a congenital uterine anomaly?
Not typically.
How can you differentiate between a septate versus a bicornuate uterus, imaging-wise?
Imaging-wise, so
What
you
would be
could
the gold
do
standard?
an MRI. I think that, well, the
Anything else
gold
you could
standard,
do?
I don't know, without non-surgery. So you could do an HSG or an MRI or surgically.
Hold on a second.
Okay.
So an HSG can tell you the difference between a bicornuate uterus and a septated uterus?
I'd have to, maybe not actually.
So how would you differentiate between the two?
An MRI, you can.
Anything else you could do?
Otherwise, you can do like concurrent hysteroscopy and laparoscopy.
So what are you looking for there?
So I think if you, well, depending on the extent of the septum, it may be apparent. Obviously, if it's not extending like the full length of the cavity, then it may just be apparent that it's a septum. But if it's unclear, I think there's something you can do with like trying to transilluminate through the fundus and watching laparoscopically, although the details are escaping me and I would definitely have to look that up before I would discuss it with a patient.
So you're saying that you do a laparoscopy and you can tell if somebody has a septum?
So I believe the part of the reason for doing the laparoscopy is also to be able to simultaneously look at the fundus of the uterus and see what the external contour is,
And what are you looking for?
whether it's smoother or whether there's an indentation.
And what if there's an indentation? What does that mean?
So an indentation could be associated with an arcuate or a septate uterus, depending on the depth of the indentation.
I'm sorry, an arcuate or septate uterus, correct? Is that what you said?
Yes.
So if I see an abnormal contour, the patient has a septated uterus.
Potentially.
Now, what would I see hysteroscopically?
So you may, I mean, you could visualize the septum, like when you enter the cavity.
So when you do a hysteroscopy, you could tell the difference between a septated uterus versus a bicornate?
I don't, if it extends the full length of the uterus, I don't know if you can, but sometimes the septum will only extend a portion of the uterus, so there's not two fully separate appearing horns. So in that case, I believe you would be able to.
So then how would you differentiate a bicornate uterus surgically?
I'm not sure.
So can you explain to me how you repair a septated uterus?
So you can resect it hysteroscopically. And that is another scenario in which you could use concurrent laparoscopy in order to visualize and ensure that you don't resect too much of the tissue. And so typically after the resection, you can also then place some sort of like a Foley balloon to help prevent scarring during the healing phase, to not prevent or to help prevent like Asherman's from your resection.
Is there anything else you could do to avoid any scarring?
Give estrogen.
What does that do?
Just helps with healing.
What do you mean by healing?
I don't know.
So if somebody has a bicornate uterus, are you obligated to repair it to have a successful pregnancy?
No.
Let's say a patient has had multiple miscarriages and looks like has a bicornate uterus. Is there any surgical procedure that can be done in order to correct that bicornate uterus?
You could do, I think, I don't know if metroplasty is for a bicornate uterus, but you can, I think, yeah, resect and then kind of reapproximate to try to form one uterine
So how would
cavity.
you do that? How would you do that?
I personally would send them to typically REI because I don't have any
So
experience.
what would REI do?
I am not sure.
And let me ask you again, is there any imaging study that can differentiate without the cost of an MRI, the difference between a bicornate and a septated uterus? Because a lot of insurances don't cover the MRI, correct?
Correct. So either, I
Is
can
there
say only
anything
other
else you
imaging
could
say
do?
if it's an HSG or an SIS, but I don't know that you would.
Does that clearly tell you the difference between the two?
No, I don't think you can know definitively from either of those.
Can you discuss for me what type of infertility workup you would do for a patient who has a primary infertility issue? Or any infertility, I guess, at that point anyway.
So I would direct it somewhat based on her history and whether or not she has any evidence of, comorbidities or things that may require like specialized testing. But in general, I would do an evaluation of whether or not she's ovulating. So if she reports that she's having regular menses and it seems like she's ovulating, you could just do something as simple as home ovulation predictor kits, or you could check a progesterone level. And then I would also do a semen analysis on her partner and then an evaluation of the cavity. Usually, where I trained, we did that with an SIS in the office.
So you're looking at the cavity. Is there anything else you should be assessing?
And then also looking at the fallopian tube. So could do an HSG as well to look for tubal patency.
Can an HSG evaluate the uterine architecture as
It
well as a
can.
sonohistogram?
Yeah, it could give you also some information. We did both in my experience as a resident.
Why do both?
We were typically doing the ultrasound in preparation for assessing sometimes a follicle count, or if a patient was planning IVF as like a later part of the workup, like the blood work had all come back and normal, and we knew at that point that they were going to need either IUI or IVF, we would do it to assess like prior for the mock transfer. And so I don't know if you necessarily have to, but it is how we did it where I trained.
Can you assess tubal patency with SIS?
I don't have any experience doing that, so I'm not sure.
So of the two procedures, which one gives you, in essence, more bang for your buck? Gives you more information, SIS or HSG?
HSG.
All right, let's stop there. What do you think?
Oh, that was terrible.
I think you did good. All righty, this is not an easy topic. So, and I asked you about the APS because I knew you knew it, but I just wanted people to kind of hear it, you know, because that's an important topic. So to go over it, please correct me if I'm wrong. Clinical criteria, you have one unequivocal diagnosis of vascular thrombosis, 2 greater than or equal to 1 unexplained death of a normal fetus greater than 10 weeks, or greater than or equal to 1 premature birth before 34 weeks because of preeclampsia or uteroplacental insufficiency, or greater than or equal to 3 unexplained consecutive spontaneous ABs before 10 weeks. Your laboratory criteria, your lupus anticoagulant present on at least 2 occasions, at least 12 weeks apart. Anticardiolipin antibodies present in medium or high titers on at least 2 occasions, at least 12 weeks apart. Or anti-beta 2 glycoprotein 1 antibody present in titers greater than 99% on at least 2 occasions, at least 12 weeks apart. Now, according to UpToDate, unless they've updated anything, how do you manage it in pregnancy? If you have APS with prior VTE, you give prophylactic heparin in the pregnancy. APS with no prior VTE, you can do clinical surveillance or prophylactic heparin. APS with a history of IOFD or recurrent fetal loss, prophylactic heparin plus low dose aspirin, and you should continue the anticoagulation for 6 weeks postpartum. I know you said something a little bit different, Caitlin, so I don't know. I'm assuming you're more up to date than the up to date. What are your thoughts there?
I would trust them. I think that they definitely know more than me. I know in the table, some of them are optional as far as, like the surveillance versus the treatment. And
so I
there
guess
are
the
some
take
cases
home,
where
if you have a history of VTE, you got to treat.
Yes.
Right?
Right.
Okay. It's a little bit on the fence if you do not have a history. But you would treat them anyway because of the recurrent losses, because that's how you end up doing that workup, right? For the most part, right? So in the end, the patient would.
So I wouldn't give them Lovenox. Sorry, what was the question?
No, because if you're doing recurrent, if they've had recurrent losses, that's a situation to treat, right?
Right. Yeah. So if someone had antiphospholipid testing that was discovered for another reason, like say you did it for like early onset preeclampsia and they hadn't had a loss and they didn't have VTE, I wouldn't necessarily Lovenox those patients, but the ones who've had the recurrent losses, I would.
Got it. Okay, so in regards to congenital uterine anomalies, an arcuate uterus is a variant of normal. So you do not have an issue in regards to increased risk of loss or preterm labor. It's a normal variant. So it's a slight midline indentation with minimal and often broad fundal cavity, classified as a normal variant. It's suggested at ultrasound when there is a deviation of endometrial cavity at the fundus with a less than 1 centimeter fundal indentation and angle of indentation greater than 90 degrees. You're at increased risk with a, let's say, a bicornate uterus for preterm labor, malpresentation, IUGR. What other organ systems can be affected with, let's say, a bicornate uterus would be, you could have an abdominal wall issue, inguinal hernia, renal, skeletal issues. And 20 to 30% women with a CUA may have a renal anomaly, and the side that's affected, let's say you have a unicornate uterus, for example, if the renal anomaly is present, it's typically ipsilateral to the congenital uterine anomaly, usually. Okay, so how do you tell the difference between a bicornate versus a septated uterus, right? So if you put a hysteroscope in, you will see a septum, but you cannot sometimes tell the difference between a septum and a bicornate uterus, right? Because let's say the bicornate goes all the way down, it looks like a septum, but it's really two cavities, and it's going to look like that with the septum. So then you would look above with a laparoscope, and if you have a heart-shaped uterus, so the fundus is indented down, that's a bicornate uterus. You do not have a smooth fundus. Am I making sense? You will not be able to tell if somebody has a septum from the fundus. Am I making sense?
Yes.
Okay. You can tell me no, you don't, it doesn't make sense.
No, you are. It's just things I
Okay,
have
so
not
if
thought
you
about
have
in a
that,
long time.
have you ever heard of that heart-shaped uterus? That's
Yes.
bicornate uterus. So that's the gold standard. However, you can use a 3D ultrasound, and that's the recommended modality according to UpToDate, because it can simultaneously visualize both the external, the serosa, and the uterine cavity contours. So you could see the indentation of the uterine fundus, and then that would tell them that it's bicornate. And you could see the septum underneath. Does that make sense?
Mm-hmm.
Okay, so a 3D ultrasound. MRI is very expensive, but when you UpToDate says of the two modalities, they prefer the 3D ultrasound. So how do you correct or repair a uterine septum? Now, if somebody has multiple miscarriages and they have a uterine septum, the recommendation is to remove that septum. The septum is avascular, so if a pregnancy adheres there, you're going to miscarry because the pregnancy can't grow because there's no vasculature. So I've seen patients, I don't know if you have, Caitlin, where they miscarry multiple times, they get the septum removed, they are able to keep kids to term, no problems. So you do what's called a metroplasty, and you perform it in conjunction with a laparoscopy, like you said, so you can see where the light is going through, translumination. So, because you don't want to go all the way through, because realistically, when you remove a septum, you're not going through the muscle, so that patient can deliver vaginally. If you start cutting through too much and you're hitting that myometrium, at that point, you're going to have some issues. And you could cut through, God forbid, you're hitting bowel or something on the other side. So that's why you should be doing it with a laparoscope. Does that make sense?
Yes.
Okay. Now, in regards to a bicornate uterus, okay, this is more of a historical procedure, but it's a procedure that exists and is only performed in patients with a history of poor pregnancy outcome that is thought to be related to the anomaly. Okay. The patients with a partial bicornate uterus with an indentation that is less than 1 centimeter are not associated with an increased risk of adverse pregnancy outcome, and thus do not benefit from this procedure. So you have to, because it's a pretty significant procedure. And once you do it, the patient will need a C-section for the rest of her life, probably could increase her risk for an accreta and so on and so forth. Because literally what you do is it's called the Strassman operation, where you make a transverse incision across the uterine fundus from one cornea to the other so that both uterine cavities can be visualized. And then the two cavities, the uterine cavities, are united into one by closing the incision in the opposite vertical direction with layers of interrupted suture. But again, it's rarely done because the thought process is it's not going to be of much benefit unless you can prove without a shadow of a doubt, and I don't know how you could do that, that the reason she's having the poor pregnancy outcome is because of her bicornuate uterus. And a lot of patients, they either deliver early or they end up with a C-section or something like that, but they're able to carry a baby. Am I making sense?
Yes,
So questions on that? Did we go over everything that you talked about?
I think so.
To clarify in regards to a hysterosalpingogram and a sonohistogram, you're correct. The HCG gives you more bang for your buck because you can evaluate the tubes. Now, can you evaluate the tubes with SIS? If you infuse fluid and you see free fluid in the pelvis, you know one of the tubes is open, but you don't know which one.
Okay, that makes sense.
Does that make sense?
Yeah.
Not that I've ever done that, but that's what the book says. Questions on that?
No, that makes sense.
Okay, any questions on any other things that we talked about?
I don't think so. That was helpful.
No, I think you did good. So APS is an important topic. So other questions there? I'm seeing if anybody has any questions. And of course, I'm having problems with my cursor. Are you still there with me, Caitlin?
Yes.
With a show of hands, can you show me if the, okay, because I don't know if I'm losing you guys or not. I'm trying to see if we can get one more person in the hot seat, but I'm having difficulty just moving my cursor. I haven't lost connectivity with you guys, have I?
No, we can still hear you.
Okay, but I'm having difficulty trying to find, I can't move my cursor. I don't even know where my cursor is at in order to pick somebody else. Wow. You can hear me there, Caitlin? I don't even know where my cursor's at.
Yes, I can hear you.
Caitlin, are you there?
Yes, I can hear you.
Caitlin,
Yes. Hello?
you never lost me?
No.
Have you lost me at any point?
No.
You have lost me?
No, I have not.
You have not. Okay.
I've been able to hear you the whole time.
I cannot move my I cannot move my cursor. I cannot move my cursor. And Carissa, can you raise your hands if you can see me? Because the only people I can see on my list, because I can't move the list. Can you show with a raise of hands? Because I know Caitlin can hear me because I have her on the line. Oh boy. Are you there, Caitlin?
Yes.
You can hear me, Carissa? Okay, hold on. Oh goodness. Okay. Okay, so they are raising their hands. Okay, I'm trying to see if I can get one more person in. Oh boy. And the cursor's not moving. It like moves and then it goes down. Caitlin, any questions before I get you off the hot seat?
No, thank you.
You did great. Thank you so much. And thank you for letting me pepper you with the MFM questions.
No problem. Thank you.
Carissa, are you there?
I am. Hello?
Are you there, Carissa? See, I want to fit somebody.
Yeah.
It's not me, it's the GoToWebinar. Hear me, right?
Yes,
I don't know if I'm going to
can.
be able to get your list because I can't move my cursor.
That's okay.
The magic of technology or lack thereof. Okay, oh look, it's moving. Sweetness. Any concerning case?
No, not that I can think of off the top of my head.
So you want to do a GYN?
Sure.
Seeing
since
we did
the other two.
office. Oh boy, here we go. So I never lost you guys.
No,
You heard me the entire time. Okay, cool.
correct.
I don't know what's going on. I've never seen this problem with the cursors. And I have clear connectivity. It has not gone away. Are you a generalist or subspecialist?
I'm an REI fellow.
Well, then you pick the group. You want to do OB then? Because you should know, or you want me to really be nasty on GYN or something?
OB or GYN.
Anything you would add? Let me
fine.
ask you this. Anything you would add in regards to congenital uterine anomalies? Because I know the
We
Strassman operation's rarely
like
done,
not
but it
done.
exists.
Yeah, not really done. And
Exists. Yeah.
it does exist. I've never done one. For our septate uteruses, when we do the surgeries, we don't do laparoscopy with it. It's just the hysteroscopy.
So how do you know how deep to go? You
I
leave a
mean,
little
it's
bit
gonna
of the
start
septum just to be on
bleeding.
the safe side?
You make it arcuate. The goal is to make the
Okay, all right. There you go.
arcuate.
That's good info. You make it arcuate. Cool. Which is a normal variant.
Exactly.
So that's 1 centimeter abutting into the uterine cavity.
Correct.
All right.
And then with your saline ultrasound, we actually just instill agitated saline, so bubbles, and that's how we test tubal patency during a saline ultrasound. And you can see the bubbles.
So you would
go
see
on
the
each side.
bubbles in the tubes.
Mhm.
Well,
You
look
can
at
see them
that.
come
I
out
never
each
saw
side.
that. You would see it come out on, look at that. So there you go, Caitlin. So I did not see that on Up to Date. So what's the, what agitated
Sometimes
saline?
it's called it's called a hycosi or a FemView procedure.
Okay. Wow.
But you can just tell them that you use agitated saline because you just
And let me
put
ask
some
you
air
this.
in it.
Is the reasoning behind doing that is because the HSG is so much more uncomfortable?
Correct. And we can just do this in our
Yeah.
own office. We don't have a C-arm to do the HSG in our office. So we do the saline procedures instead, and they're way better tolerated.
So let me ask you this, because I know there were again, don't say studies on the exam, but some patients are able to conceive after an HSG. They believe that pressure of putting that fluid through the tubes opens up the tubes. Is that the same thing with the?
We sometimes tell patients that, but it has not been studied in the same regard. So I'm not sure if it's truly the pressure or if it's the dye that's being pushed through or what it is, but we don't have evidence to show that.
Okay,
for saline.
Interesting. I did not know that. I've learned something new. Anything else you would add? Because again, I'm a generalist.
No, I thought that was
You
a
guys
very
know-
thorough discussion. We usually start our workup for recurrent pregnancy loss after 2 losses, because ASRM says to do that for clinical evaluations.
Okay, awesome. Anything else you would add?
No, I think that's it.
So I'm here trying to see if I can move your list, and of course I can't move it.
We can do the first one then.
Let's do number one, because number one, you know, everybody's gonna look at number one. They're not gonna give you, you know.
That's
so you
true.
hopefully you have a good number one and your good last one, because you know they're gonna flip to the first and the last.
I didn't really think about this when doing it. I think it's
your problem
chose for me.
hopefully your problem case is in the middle and they miss it. You know, that's what you try to do, right? Hopefully they won't see it, you know. So in regards to case number one, what made you decide in regards to your evaluation in the clinic on to do this procedure laparoscopically? I'm assuming it was a TLH, correct?
Correct. Actually, this was a TLH. I was trying to remember if it was supracervical, which because I wrote laparoscopic hysterectomy. So this one was actually a supracervical hysterectomy because the patient desired to maintain her cervix.
So this one was supracervical.
Correct.
Okay, you didn't include that in your, so be prepared. Oh,
Okay.
we lost it. Are you still there? Did I lose you?
I'm still here.
Did you see something pop up on the screen? I don't even know. Hold on. Oh
No.
boy, I don't know what's going on. I don't know if I'd be able to move this down. Oh goodness. Because I can't see you may have to, I want everybody to see it, but I can't move anything.
Second case is similar, but it's not as big of a uterus.
Okay, so. All right, well, that's not a supracervical?
No, that's a TLH, the second one.
That was that a supracervical?
This
Dang.
one's not.
I can't move back up. Let me try something, hold on.
Okay.
I'm trying something, like I'm smart now. Darn tech. There we go, I just opened and closed. And usually I have a thing on the bottom where I can make it bigger. Oh, there it is. How's that? I'm not touching anything.
Great.
So what made you decide? So it was a supracervical, okay, because you didn't
Correct.
include that. So be careful.
Yes, I noticed that. Yes.
Okay, so bring that up. Very good. So what made you decide? Do
So I decided this to proceed laparoscopically due to the size of her uterus and the fact that she had not had any previous vaginal deliveries. I did not think this was an approach that I could do vaginally. She has not had prior, she'd only had an appendectomy before, no other major surgeries on her abdomen. So I didn't have high concerns for excessive scarring inside of her abdomen. So felt that we could attempt this laparoscopically to maintain it, keep it minimally invasive, and then if necessary, convert to an open procedure, which she was aware of when we started the surgery, given the size of the uterus on her exam. And
so how did
imaging.
you enter the procedure laparoscopically?
So I entered anterior to the umbilicus, about 2 centimeters above the umbilicus, so that I was above the uterus for the procedure. If I entered at the umbilicus, I don't think I would have had enough space.
So how did you enter?
So I start with the varus needle insufflating at the umbilicus. I lift the umbilicus up using penetrating towel clamps and create a stab incision, and then insufflate the abdomen with the varus needle, making sure that when I'm insufflating that the opening pressure is low. And then after I have adequate insufflation.
What's low? What's low?
Low would be less than 5.
Okay, continue.
And then once I have insufflated the abdomen, then I made a 5 millimeter incision with a scalpel and above her umbilicus, and went in with a direct laparoscope.
Like an OptiView?
OptiView, correct.
Now, what energy source do you use in your laparoscopic cases, and why?
I use I'm sorry, the name of the instrument that I use every day is escaping me right now. It uses ultrasound energy, so it's heat that's created with the device to coagulate and cut the tissue. I choose this because it has less thermal spread than the ligature device. And I can also use it to the underside blade like a scalpel to dissect a little bit more finely the tissue around the uterus.
So you're talking about a harmonic scalpel?
Yes, thank you.
Okay. Now, see, you did a supracervical. Did you do anything special at the stump?
At the stump, I do cauterize the cervical os to decrease the chances of bleeding, and then to decrease the chance of adhesions, I put an adhesive barrier over the stump in case, for some reason, if I have to come back at a later time to do a trachelectomy, to decrease the chances of excessive scarring.
So how did you take the specimen out?
I made a mini laparotomy incision above the pubic symphysis, about 2 to 3 centimeters in size, and within a laparoscopic, within a excision, within a bag, brought that to the skin and morcellated at the level of the skin.
Now, let's say she wanted the supracervical, correct?
She did, correct. Our recommendation had, My recommendation generally is for a total hysterectomy, but this patient felt very strongly about maintaining her cervix. She had normal cervical cancer screening in the past, so our shared decision making, we decided to proceed with the supracervical hysterectomy.
So let's say she wanted a complete hysterectomy with the cervix removed. Would you have been able to do this procedure as, what other modality would you use to do the procedure?
So
Am I
again,
making
I
sense?
think, yes, I think given the size of this uterus, it would have been very difficult to attempt this vaginally. Given the size and the fact that she hasn't had vaginal deliveries in the past. Another factor that would have been a problem with the total laparoscopic approach as well would take a long time to try to morcellate this uterus out from the vagina as well. But again, I think we could have done that too if she had wanted her cervix to be removed.
So you don't think you could have done an LAVH?
We could have. I think accessing the uterosacral ligaments from below, it could be accomplished, but I liked having the visualization from above given the bulkiness of her uterus from the leiomyomas. I still liked this approach. I would do this approach again for her.
Now, can you you said you did a mini laparotomy. Can you discuss other skin incisions that you can perform during a laparotomy?
I could have done a larger incision, so she could have had a midline incision for a laparotomy or a fan and steel incision for her opening for a hysterectomy. These would have been larger incisions that I don't think we needed to do in this setting unless we were performing a total abdominal hysterectomy.
Let's say in general, what other skin incisions can we do?
Other than a midline vertical or a fan and steel incision, those are my two go-to incisions to make. I'm not sure.
So is there a third or fourth go-to?
Not that I can think of.
So can you describe for me the counseling you undertook? I know she had a 17-week size uterus, but what counseling you undertook with the patient in regards to her treatment options for her abnormal uterine bleeding?
Yeah, so this patient, since she was 50 and nearing menopause, we did discuss that her bleeding that was related to her fibroids could potentially improve with menopause. So fibroids generally start to shrink with menopause, but given the overall size and impact of her fibroids, it's unlikely that they would shrink enough to no longer have the complete normal size of a uterus by the time she completed menopause. We discussed other medical managements for fibroids, which would include hormonal therapy. I don't think an IUD would work well given the locations of her fibroids, but that sometimes can be helpful as well. Or in her case, since she's bridging to menopause, we could potentially give her Lupron as well, so our GnRH agonist treatment to help shrink the fibroids as a bridging therapy towards menopause or towards surgery.
Any other options?
She could do uterine artery embolization or it would be uterine artery embolization for her would be an option as well to decrease the blood supply towards the fibroids.
So what's a contraindication to uterine artery embolization?
Undiagnosed abnormal uterine bleeding.
Anything else?
I think that's a large contraindication for it. I'm not sure of others off the top of my head.
Would you be concerned with the size of her uterus that she would not be a good candidate for the uterine artery embolization?
I would be concerned that she would have significant pain afterwards and that it might not work. if the embolization does succeed, then pain from the necrosis of the fibroids, and it could require her to be potentially even hospitalized for the pain and discomfort afterwards. I would be concerned about that for her.
And is there any particular fibroid, if present, could cause more issues with a uterine artery embolization versus other types of fibroids?
I would think a pedunculated fibroid could cause the most problems because it could necrose and more likely to necrose since it has a thinner attachment and blood supply. But I'm not 100% sure on that.
Any other type of fibroid?
I'm not sure.
Now, do you do robotic surgery?
I do not.
Okay. If you did robotic surgery, would you have done this procedure robotically?
I think the reason I don't do robotic surgery is we have other surgical assistants with us, so fellows, residents, and attendings who can scrub with us. So we have a second pair of excellent hands to assist. But if I did not have an assist that could operate at my level, then using a robot seems like a reasonable way to get a third extension of me. So I could have a third arm that could have helped me to move this uterus around. So yes, I do think it could be helpful in that setting.
But you would do it more for an assist?
Correct.
The robot. You didn't think you had
Correct.
any issues in this case being able to get all the pedicles?
No.
So would there be any concern, anything that you could do before the surgery in preparation if you felt that because at 948 grams, that's a pretty big uterus to be able to see what you needed to see in order to do the surgery? Because if you had difficulty seeing, let's say, in the area of the cardinal, as an example, you would not be able to do the procedure, correct?
Correct.
So anything you could do before in preparation if you were concerned for that?
Yeah, consideration is always using Lupron to shrink the fibroids preoperatively.
How much would the uterus usually shrink?
I think it shrinks up to 30 to 40%. The fibroids shrink 30 to 40%, not the entire uterus. But it does grow back. So it's particularly a bridging therapy to get you to surgery. The downside to it, not so much with a hysterectomy, more for a myomectomy, is it can make the planes a little bit tougher within the fibroids.
What's the mechanism of action of Lupron?
Lupron is a GnRH agonist.
What's that mean?
It means that it works at the level of the hypothalamus and stimulates the GnRH receptors and binds to them in such a way that your body then stops sending down FSH to your ovaries to make estrogen, and it inhibits the negative feedback loop of the HPO axis.
All right, let's stop there. What'd you think?
It was good. That was great because it got me to questions that I realized I didn't know a lot of information about.
Okay, skin incisions. There are more skin incisions. I'm shocked that you didn't think of these. The maylard and the cherney. You ever heard of those?
I think, yes. I think I was thinking more like superficially on the body, not deeper on the muscle layers of where the incisions were.
I said any skin incisions.
Yeah.
You could do a Joe Cohen, your fan and steel, your vertical, and there's a lot of other ones. But I think the ones that they're always looking for is maylard and
Maylard and churneys, yep.
So what's a maylard?
I believe maylard is one of them is removing the muscle from the pubic symphysis, and I want to say that's a maylard, but I can't remember. And then
that's the cherney. So the cherney and anterior rectus sheath that may be dissected from the muscle. The tendons are cut at their incision to the symphysis. With closure, you reattach to the insertion site. It's a good incision for exposure to the retropubic space of retzius. Back in the old days when they used to do birch procedures for incontinence, you can consider that incision. The maylard, the rectus muscles are incised transversely. Prior to this, the inferior epigastric vessels are isolated and transected. Dissection from the anterior rectus sheath should be avoided in order to limit retraction of the muscles. Contraindications to a uterine artery embolization, future fertility, postmenopausal, contraindication to contrast, right? Because then you can't,
Okay.
do the procedure. They say more so, it's more, I mean, it does help with, abnormal uterine bleeding, but it's better if somebody has symptoms of bulk symptoms from the fibroids. Apparently, supposedly, that's what it assists much more in regards to that bulk symptoms, that pressure the patient's complaining about. So what type of fibroids could be of issue? The pedunculated, that have a narrow stalk, so the stalk less than 50% in diameter to the fibroid. The fibroid could detach and lead to sterile peritonitis. So that's a theoretical risk, even though, again, don't say studies. There's no studies have really shown that that's an increased risk. But that's a theoretical risk, right? It should make sense.
Yeah, that makes sense.
Number one. Number two, because I review a lot of case lists, and you see a lot of people undergoing uterine artery embolization for submucosal fibroids, and I really don't understand why. Because if you have a submucosal fibroid, why can't you just do a hysteroscopic myomectomy? I understand she may have other fibroids, but if you're complaining of abnormal uterine bleeding, can't you see if you could take out that submucosal fibroid and see if that bleeding improves? Am I making sense?
Yes.
So then you do a submucosal, you have a submucosal fibroid, you do your uterine artery embolization, and you may have some other fibroids, intramural or whatever. And then the next thing you know, you got this submucosal fibroid necrosing coming out. Sometimes you pass it, sometimes you don't, sometimes rarely you have to take them to the operating room because you got this necrotic funk inside your uterus that's not coming out, and it smells terrible. And you'd have to do like a hysteroscopy in order to remove this fibroid that can't come out of your uterus. Am I making sense?
Yes.
So you would end up with you should have done the hysteroscopic myomectomy from the get-go. It's the way I see it. Because you do have a lot of that discharge, and it's really it's funk, man. It's funky.
Yeah, I don't recommend uterine artery embolizations very often.
It's an option, but I mean, I think you really got to pick your patients, and I'm not to malign any specific, specialty or anything, but the radiologists, they'll do the procedure, but they don't have to deal with the issues afterwards. And then as the gynecologist, we do. When the patient keeps coming in complaining of this discharge and it's nasty, I mean, it's gross. And it's like, and I remember I had this patient, I go, that's the side effect of this. And she's like, I researched it thoroughly. I'm like, well, the first thing you Google uterine artery embolization, the first thing it says is significant discharge. And she got really mad at me. I'm like, I'm sorry, it's what it says, and here you are with that complaint. She had done it like 6 months before, so it wasn't like recent or anything like that. She was still having complaints of the discharge. Any other questions? I'm trying to remember what else. Nice in regards to, so I was trying to, and I like how you said, I forgot the name of the apparatus, but this is the way it works.
Thank you.
And me trying to say, oh, well, can you do this procedure another way? That, and you said, I really don't think, and I just wanted to bring up, because everybody does the robot, so that's why I wanted to bring up, at 9:48, why you didn't do a robot. So that's pretty awesome. That's your first case. You have it as laparoscopic.
Thank you.
And then the idea of the Lupron to shrink things. And in the old days, we used to give the Lupron in order to see if we could do the surgery vaginally. I'm not going to say you'll be able to do a 9:48. I can see somebody, if they wanted to be, push you, they could say, could you do this case vaginally? And some people are of the theory you could do any case vaginally if you know you got your uterines and you just start like bivalving the uterus. And little by little,
and is it okay for me to say no? Like that
oh no, that's fine.
Okay.
No is fine because you feel comfortable. And I'm not saying what you did was wrong. You defended it by saying, yeah, I didn't feel she had good descensus, But sometimes they'll push you. Are you sure?
And I don't have any vaginal hysterectomies, so I'm sure they're going to try to get one of mine to be a vaginal at some point. But
it's possible. I mean, I had at least one of every. hysterectomy, so I didn't have that problem. But I know people, they even have robotic tubals. And I'm like, well, how are you going to defend that? They passed the exam. So as long as you defend what you're doing, that's what's important.
Okay.
Okay? But I
Great.
think you did a good job.
Thank
Other
you.
questions? Because I just want to wrap things up just in case it kicks us out of the call. Because somebody told me that at a certain point, it kicks everybody out. And I'm sorry
Thank
for
you
any
so
technical
much.
difficulties that I had. So now I can go to you when I have any of my REI questions.
Sounds good.
All right, you did a great job. I don't know how much I can move around. I'm moving my cursor, so I think I'm doing good. Now I'm stuck. Does anybody have any questions? And I don't know if I'm going to be able to see if anybody has any questions, and my apologies. It looks like I'm able to move my cursor here, and then I get stuck. It's like when I'm trying to move, let's see what we can do here. I'm just trying to see if anybody has any questions. I see Sasha has her hand up. I'm trying to get to Sasha, but I'm having some difficulty moving the cursor. I don't know if you guys can see the cursor, me kind of moving around like a fool. It's not moving. I'm here trying, Sasha. Oof. Let's see. Wow, what's going on? Okay, so Sasha took her hand down. I guess she doesn't have any questions. Okay. I'm trying to see if anybody has any questions. Where is the cursor? So I see Sasha has a question in the box, but I can't get to the box. So hold on, Sasha. Let me see what I can do. And my apologies if I lose you guys. I'm just trying to see if I can go to the. I'm trying to get frozen.